Welcome, everybody, and I am glad that you've joined us today for this webinar on developmental evaluation of ASD. We have a number of people on today, so just in the interest of our bandwidth and trying to make sure that we don't have any technical glitches, I am going to go off camera and continue the presentation from there, and I'll come back toward the end. So just in terms of disclosures, I do want to let you know that I am employed by Pearson Clinical Assessment, the publisher of several of the assessments that we will reference during the presentation. There is no relevant non-financial information that I need to disclose. In terms of our learning objectives for our session today, we would like you by the end of our time together to be able to list the prevalence rates for ASD, autism spectrum disorder in the United States, to describe the areas that need to be assessed for a comprehensive ASD evaluation, and then to discuss some variables that may impede the diagnostic process when we are working with children with ASD. We're going to start out by talking about the prevalence rates of ASD. We'll talk about the diagnostic process for ASD, factors to consider when evaluating ASD, and then we'll leave some time at the end for questions and answers. But in the meantime, if you have questions, if you'd enter them into the chat box, and my colleagues will respond to questions. So to get us started, I want to think about a few of the individuals who might be referred for what I'm going to call an autism evaluation. So I want to start out by talking about several individuals for whom we received referrals at an autism clinic, and some of these were received as part of school-based teams. So for example, the first one is 5-year-old Jack, who has been walking up and down the stairs in his home since he was 14 months old. But sometimes when he's walking on a flat surface, he might fall to the ground, and it seems as if his legs can no longer support his weight. He does speak in sentences and narratives, but strangers sometimes have a difficult time understanding his speech. When he's in a crowd, he sometimes begins to scream and run around in circles for no apparent reason. And some adults in the room do exactly what we think they should do, right? They regard him with compassion. Others take their children to a different location. We understand that response as well. His parents wonder if this behavior is due to sensory overload on Jack's part, especially because they seldom see the behavior at home. Now, Jack has received early intervention since he was 18 months old from both a speech-language pathologist and a physical therapist. And we'll come back to Jack here later. Another referral for an autism evaluation was 11-year-old David, who is in grade 6. And he was referred because he has trouble interacting with peers. He has trouble understanding non-literal language, ambiguous language. He has trouble inferring information that isn't stated explicitly, either orally or in text. Again, you're thinking about a number of characteristics. Jack, who's 5 years old, David, who's 11 years old. You're thinking about the presenting information as being slightly different. Now, Angie, and I've talked about 2 boys so far, and here's my first girl. Angie is 3 years, 7 months old, and her teacher in the Head Start program referred her for testing. And her teacher reports that Angie's speech seems delayed. She follows directions. However, she seldom speaks, and she prefers to communicate by pointing and gesturing. When she does speak, she uses 2 or 3 word phrases rather than complete sentences. Again, think about the presenting concerns and think about how we need to proceed when we receive this evaluation. And here's another one, Michael, who's in grade 5. and his teacher referred him for comprehensive psychoeducational evaluation. This was a referral to our school-based team because he was struggling to master grade level objectives. Now, the interesting thing about Michael is that he had earned above average grades on his report cards in the early grades, kindergarten, first, second, and third grade, but his grades have been dropping steadily since fourth grade. What we note from the information the teacher provided is that he performs well when he's reading words in isolation. As a matter of fact, he performs at a very high level when he's reading words in isolation, but he has difficulty answering comprehension questions. In addition, he does well with written math, but struggles with word problems. Again, that kind of raises my antenna a little bit. He does well on basic reading, struggles with reading comprehension. He does well with basic math, which probably would be like numerical operations, adding, subtracting, knowing which procedure to use to solve a problem, but he struggles with word problems. Now, in terms of what happens outside of the classroom, during lunch, he sits alone in the cafeteria. And when his teacher noticed this the first time, she invited him to join his classmates, and he told her that he doesn't want to sit with them because they are stupid. So again, you're thinking about the referral information and thinking what this referral information tells us about how we need to proceed in terms of selecting assessment instruments, in terms of thinking through which components should be included in the evaluation, and I'll circle back to these individuals later. But one of the things that I want you to see when we think about these individuals that I talked about here, I actually figured out that I should have had a fifth child, which should have been another boy, but I didn't do that, and I'll tell you why here in a second, why 5 would have made sense. Now, one of the things that you probably noticed, I was talking about a 5-year-old, I was talking about a 3-year-old, I was talking about an 11-year-old, I was talking about a 5th grader who was 10 years old at the time. So you're thinking about the 10-year-old, you're thinking about the 11-year-old, and you're thinking, well, they are referring because they are concerned about autism spectrum disorder, and isn't this a little late to be making that diagnosis? Now, when you look at the information from the Centers for Disease Control, we find that although the age at which children are diagnosed with ASD has been dropping consistently, the diagnosis still continues to be made late in a number of situations. Most children are diagnosed after the age of 4, although the research is clear that we can diagnose autism reliably as early as age 2 years. When we think about the fact that autism affects all ethnic and socioeconomic groups, and that minority groups tend to be diagnosed later and less often, those factors really lead us to think about some of the factors that we need to keep in mind when we are working with individuals who might be classified with ASD. What can we do to make sure that we increase the age, or that we lower the age at which individuals are diagnosed with ASD, especially when we think about minority groups. You're thinking about African Americans and Hispanics. And the reason that we say that we can reliably diagnose autism as early as 2 years is because really, when you think about infants and toddlers, there are some early warning signs, right? Like an infant or a toddler who is not maintaining eye contact, or who's avoiding eye contact, who doesn't look when you point to an object. I will talk more about pointing when you does not look when you point to an object. I'm going to talk about that concept, joint attention, which is really an important red flag indicator when children don't look when you point to an object, or the opposite is the case as well if they don't try to get your attention when they want an object. So for example, if the child is playing with a ball, the child is seated in mom's lap and I'm across the table, the child is playing with a ball, and I guess accidentally, in quotes, really deliberately make the ball fall to the floor, because what I'm trying to see is whether or not the child is going to get my attention to let me know that she wants me to pick it up. Again, that joint attention is really important when we think about early warning signs for ASD. Children who don't engage in pretend or imaginative play, if I try to initiate maybe a peekaboo game with a child by covering my eyes and saying peekaboo, and the child really doesn't pay attention, to me when I try to initiate or to get his or her attention. Children who don't respond to their names. So if you think about developmental assessments, like for example, the Bailey 4, you'll notice that the items on that tool and on other developmental tools really have items that focus on these areas, right? To see if the child is going to be tracking visually, if the child is going to look when you're pointing to an object. We have items that assess pretend play, imaginative play. We want to see how you respond to your name. Maybe you're not using gestures to communicate. I remember this little boy, he would ask me at the time, maybe he was about 11 months, and he'd want something, and he would try to get my attention, and he would try to vocalize. And of course, I don't understand what he's saying at that age, but then he would point, and if I still didn't understand, he would actually grab my hand and take me to what he wanted. So children really find creative ways to communicate, to get what they need. You might also see children engaging in some ritualistic, some repetitive behaviors, stereotypic behaviors, like excessive lining up of toys or objects. They're not smiling, they're not socially responsive. There's this story about excessive lining up of toys or objects where a mom talks about her going to this mom's group. And typically when you go to these mom's groups, you bring your infant or your toddler. And of course, the infants are crawling around on the ground and they are crying and they're trying to hold on to their moms. And she said when she went to the first group meeting, one of the other parents, they were sitting together, and the other parent said to her, "Boy, look at my son. Look how he's crawling and he's crying and he's whining, and your son is just sitting over there quiet as a mouse, lining up his cars, right? Red, white, blue, red, white, blue. He's not making any noises, no vroom, vroom, like my son does when he's playing with his cars." And mom said if she had known then what she learned shortly after that, her antenna really would have gone up right away, because those repetitive stereotypic behaviors really are early warning signs that maybe we need to go to our developmental pediatrician to get some information about what we're seeing, right? So again, there are some warning signs that are there early, and it's really incumbent upon certainly parents, but also individuals who interact routinely with families, such as developmental pediatricians, to be familiar with these early warning signs. The other thing that I hope you saw from those 4 individuals that I talked about was that there is variability in terms of their symptom presentation. Like, for example, it sounds like for Angie that she's really struggling with speech production. Now, our assessment is going to bear that out for us. It's going to confirm or refute that hypothesis, right? When you think about Jack at the beginning, especially when he appears to be running around screaming, certainly that might be a little more severe compared to what you would expect from a typically developing child. So variability of symptom presentation is really important when you think about ASD, but also when you think about some of those early warning signs that'll allow us to be able to diagnose at an earlier age. Now, when we think about the prevalence of ASD in the United States, and every year, whenever a report comes out from the Centers for Disease Control, or this information I pulled from Autism Speaks, you always notice it seems like the prevalence rate tends to decrease. And from the 2016 data, the estimated autism prevalence for 2020, the autism prevalence for 2020 was estimated based on the 2016 data. And based on those data, we estimate that by 2020, the prevalence rate would be 1 in 54 children. 1 in 54 individuals would be diagnosed with ASD. Now, the reason I talked about having that fifth referral was because boys are 4 times more likely to be diagnosed with autism than girls. So I thought, well, I should have maybe 4 boys and 1 girl. So the prevalence rate for boys would be 1 in about 34, compared to 1 in about 144 for girls. So again, think about this information and think about maybe some of the factors that would explain. You could see that the prevalence rate has increased year over year when you look at this pink line here, that trajectory, right? You could see that increase year over year, or from one data point to the next data point. It's not necessarily from one year to the next. The other thing that I want to talk about with respect to prevalence would be what happens in the school environment. So if we think about early identification, you're thinking certainly about children. So we want to make sure that we understand prevalence rates with respect to students with disabilities in the educational setting. And this information here is for school year 2018-2019, and it looks at the number of students between the ages of 3 years and 21 years who received special education services under the Individuals with Disabilities Education Act. So about 14% roughly of all public school students received special education under IDEA. And among the students receiving special education services, you could see that the largest category, 33%, received special education services under the classification specific learning disability. And then when we look down for autism, that is about 11% of those individuals were classified with autism. You could see some of the other disability categories. For example, intellectual disability was 6%, developmental delay was 7%. And this information comes from the Condition of Education report. Let's see. Comes from the Condition of Education report. That is the annual report that is mandated by the U.S. Congress, tends to summarize the latest data on education in the United States using information from the National Center for Education Statistics. And again, when you think about what this information tells us about the diagnostic process, we want to think certainly about the characteristics of the individuals that I described, but we also want to think about the diagnostic criteria that are specified maybe by our educational classification systems, and then also by maybe other classification systems such as the Diagnostic and Statistical Manual. So I want to start out by thinking about these 4 children that I just described, and all of them in terms of their age would be in our school system. So we want to think about whether or not they are eligible for and whether or not they need direct specialized instruction, and whether or not they would qualify for direct specialized instruction under the classification autism spectrum disorder. Now, The term autism, or the disability category autism, was first introduced in the educational classification system in 1990 with the Individuals with Disabilities Education Act, and continues to be included in the reauthorized IDEIA, the Individuals with Disabilities Education Improvement Act of 2004. And I want to draw your attention to a few things here, because I think that embedded within these criteria are instructions for us when we think about the evaluation to determine eligibility. So when you think about IDEA, autism means a developmental disability. So I immediately start thinking about developmental disabilities, of which autism is one, but I know that there are other developmental disabilities as well. So we need to we need to collect information that will allow us to determine if this student meets the criteria for a developmental disability, specifically the developmental disability autism spectrum disorder. Now, the developmental disability should significantly affect verbal and nonverbal communication. So I need to make sure that I assess communication. Also, significant adverse impacts on social interaction. I also need to make sure that I could document that these symptoms were manifested before the child was 3 years old. And then I also need to make sure that I can document that the disability adversely affects a child's educational performance, which means I need to have data on academic achievement compared to others the same age. And then other characteristics that are often associated with autism would be engagement in repetitive activities, stereotyped movements, resistance to environmental change or to change in daily routines. So again, I need to make sure I have some information about behavior. And then other characteristics might be unusual responses to sensory experiences, right? So I probably need to have some information about the child's sensory processing. Now, when you look at the diagnostic criteria from the DSM-5 for autism spectrum disorder, you'll see some overlap from the DSM-5 to the IDEA classification system, right? Social communication and social interaction are really important components here as well. So you think about persistent deficits in social communication and social interaction, and these are typically evident across contexts. So you think about all of the environments in which the individual functions, those deficits are manifest across those contexts. And they tend to be manifested either now or historically, right? So I need to be able to capture that information somehow so that I can document those persistent deficits in social communication and social interaction across settings, across contexts. Now, in order to meet this criterion, all three of these components that are included under category A must be met. So the child should exhibit deficits in social emotional reciprocity. And there are a number of examples that are provided in the DSM-5, and they're provided to really alert us to severity, right? So when I talk about symptom severity from mild, moderate to severe, when we look at the examples, when we think about deficits in social emotional reciprocity, that might be simply a failure to engage in normal back and forth conversation, right? That might be something that's relatively mild. Or it might be more severe where the child doesn't initiate or respond to social interactions. Similarly, for number 2, deficits in nonverbal communicative behaviors used for social interaction, that might be something where the child's verbal and nonverbal communication are poorly integrated. Or it might be a total lack of facial expressions and nonverbal communication. And then for number 3, the deficit deficits in developing, maintaining, and understanding relationships might be that I'm struggling to adjust my behavior to suit different social contexts, or much more severe, where I'm completely not interested in my peers, right? So when I was talking about the fifth grader and he doesn't want to sit with his peers for whatever reason, he's really not interested in his peers. So again, when you look at criterion A, in order for you to say yes, based on the data, the child would meet this criterion, I have to document deficits in social emotional reciprocity, deficits in nonverbal communication, deficits in developing, maintaining, and understanding relationships. So when we think about what we know about ASD and social communication and social interaction, certainly when you review the literature, and some of this information I pulled from a textbook that ironically I used a number of years ago when I actually taught a course on exceptional children. We're up to the 14th edition now. I'm not going to tell you what edition I used because that might date me. But when you think about social communication and social interaction, and we have a webinar that's coming up in a few weeks that's going to talk about the assessment of language when you think about ASD, and we'll dive deeper into the components of language with which individuals diagnosed with ASD might struggle. But you think about, for example, social responsiveness. Maybe you notice that the child doesn't smile in social situations, may avoid eye contact, some of those early warning signs that I mentioned. What about communicative intent? Maybe you can hear some abnormalities in my intonation. My speech may sound robotic. Maybe in terms of content, I'm just talking and talking and talking. Maybe my speech is echolalic, for example. So echolalia, again, we talk about quite often when we think about individuals with autism, where they are repeating words and phrases repetitively and sometimes out of context. They may be unaware of the reactions of listeners. And I talked earlier about the joint attention as being a really important early warning sign, where the child may not be using gazing or pointing to alert someone else to a stimulus. In effect, they're not initiating that joint attention. And I mentioned a study, it's a study by Freeman, Goldsworth, and Kasari in 2015, where they looked at joint attention of 3-year-olds with autism, and then they followed up years later, and joint attention of 3-year-olds with autism predicted their engagement in close and conflict-free friendships at 8 to 9 years of age. So joint attention is really one of the key indicators when you think about social communication and social interaction. We also have to talk about the pragmatics of language, right? Because individuals with ASD may use an age-appropriate vocabulary and grammar, but they may speak using an abnormal voice inflection. I mentioned the robotic nature of their speech. They may speak in a monotone kind of voice. They may struggle to take turns talking in a conversation, to read social cues. And some of the issues some researchers believe with reading social cues stem from deficits in recognizing emotions, facial expressions, and vocal intonation. One of the components when you think about the pragmatics of language, and theory of mind sometimes is discussed under the pragmatics of language. It's also discussed often when you think about cognitive ability. And of course, when you think about the mind, you think about thinking, right? And so you think about the cognition piece. So, but when you think about theory of mind, a number of children with ASD really struggle with theory of mind, where they have difficulty taking on the perspective of another person in a social exchange. So for example, well, the classic study of theory of mind difficulties, and you can Google this. I'm sure it's out there in the cyber universe. The classic study is the Sally and Ann experiment conducted in 1985, and I'm going to summarize it just briefly here. Where Sally and Ann were dolls, and the experimenters, they wanted children to come in and do something with respect, or answer a question with respect to the two dolls. And the children who were involved in the study were in one of three groups, either an ASD group, a Down syndrome group, or a no disabilities group. And so Sally, one of the dolls, has a basket, and Anne has a box. And so the child sees Sally put a marble into her basket and cover it up. And then Sally leaves the room. And while Sally's out of the room, Anne takes the marble from Sally's basket and puts it into her box. So Sally comes back into the room, and the question that the experimenter asks the child is, where do you think Sally will look for the marble? And the children in the Down syndrome group, the children in the no disabilities group, they were able to respond to that question correctly. The children in the ASD group did not seem to understand that Sally had no way of knowing that the marble had been switched, that the marble was no longer where she had left it, that to Sally's way of thinking, they struggled to put themselves in Sally's mind, thinking, well, Sally had no reason to know that the marble had been moved. She didn't see what you saw, right? So that being able to take the perspective of another person, theory of mind, is really, again, one of those hallmark features, those red flag indicators when you think about ASD. And then, of course, meta-linguistic skills as well. When you think about social communication and social interaction, they may struggle to identify and understand idioms, to understand figurative language, like it's raining cats and dogs, for example, might fail to understand sarcasm, like if I say, your brother is a real genius, after he put his hand in the flame on the gas stove, for example, right? And he's 15 years old. So again, sarcasm, idioms, understanding figurative language might be really difficult for ASD individuals. Now, that's about social communication and social interaction. But what about the criterion B, which is restricted repetitive patterns of behavior, interests, and activities? And again, for this to meet this criterion, the child must evidence two of the four categories here, displaying stereotyped or repetitive motor movements, stereotyped or repetitive use of objects or speech, insistence on sameness, inflexible adherence to routines, ritualized patterns of verbal or nonverbal behavior. Interests might be restricted, fixated, might be abnormal in intensity or focus. And then either the child is overreactive or underreactive to sensory input. So for example, you might have a child who you could see that the child fell and the child is not reacting by crying, for example, is not reacting to that pain. So when you think about restricted repetitive patterns of behavior, think about ritualistic motor behaviors, maybe twirling and spinning objects and flapping hands, maybe excessive interest in objects of a certain type, become upset when you change their routine. I want to go back to the first one here in the box on the left, which would be those ritualistic motor behaviors, because this is really important when we think about the evaluation to determine a diagnosis or classification of ASD. It's important for us to think about these behaviors and to think about the fact that these behaviors are associated with ASD, but that they might be associated with other conditions as well. So when you think about ritualistic motor behaviors, like maybe flapping hands and rocking, think about individuals who are blind. I remember when I taught that course on exceptional children, one of the terms that I learned was blindisms. And blindisms are stereotype behaviors that you sometimes see in individuals who are visually impaired. And one of the names that was always referenced at the time was Stevie Wonder. So if you think about Stevie Wonder and you see him playing his piano and you see him rocking back and forth and moving his head, are those blindisms that we talk about, those ritualistic motor behaviors? And what is really interesting, if you think about a more contemporary person, the musical genius Matthew Whitaker that everybody's talking about. Again, he is blind, and when you see him playing his instruments, you see some of those same ritualistic motor behaviors. So the important thing when we're thinking about ASD is to think about these behaviors and how they are associated with ASD, but whether or not they might also be associated with other conditions that might be related to ASD. And over to the right, I talked earlier about the hyper responsiveness and the hypo responsiveness. But one of the things that I thought was really interesting was this bottom one in this box to the right, that, and it shouldn't surprise us, right? A 2013 study talks about the fact that individuals with ASD tend to watch more television and play more video games than their peers. Now, that shouldn't surprise us. They love to be alone. They love to engage in solitary activities. But the researchers also found that they tend to spend less time than peers on social media. Now, for me as a parent, that probably would be a good thing, right? But of course, just like the mom said, it was really nice that her son was just sitting there very quietly. And this would be nice if my child doesn't spend that much time on social media, except if it was associated with ASD. Then I'd have to probably rethink that perspective. But again, if you think about social media, it is a platform for social interaction, for social communication, which is something that they don't necessarily prefer. And I mentioned in terms of the severity, there is this spectrum, and the DSM-5 talks about that spectrum. So once I am able to document deficits in social communication, in social interaction, once I'm able to document restricted repetitive patterns of behavior, for example, I need to specify the level of severity because that'll allow us to determine the level of supports that the individual will need. So you're thinking about level 3, severe deficits requiring very substantial support, level 2, marked deficits, and level 1, noticeable impairment. So ranging from some support to substantial support to very substantial support. And then some of the other components, C and D, again, just like for IDEA, the symptoms should be present in the early developmental period, but they may not become fully manifest until social demands exceed limited capacities, or they may be masked by learned strategies in later life. If you read, if you go to Temple Grandin's website, for example, Temple Grandin PhD, you will see how she talks about strategies that she has learned to cope with some of the symptoms of ASD. And then just like for IDEA, we need to document that the symptoms have an adverse effect on educational performance. For DSM, we must be able to document that the symptoms cause clinically significant impairment in social, occupational functioning, or other important areas of current functioning. And I would think for sure adaptive behavior would be one such area. And then here is where we get to that differential diagnosis, because these disturbances are not better explained by intellectual disability or global developmental delay. In other words, in order for me to diagnose ASD, I must rule out intellectual disability or global developmental delay. Why? because these two conditions frequently co-occur. And in order to make that comorbid diagnosis of autism spectrum disorder and intellectual disability, social communication should be below that expected for the child's general developmental level. In other words, for the child mental age as opposed to the chronological age. And then I also need to specify, does this ASD, is it accompanied by intellectual impairment, by language impairment? Is it associated with a known medical condition? Is it associated with another neurodevelopmental, mental, or behavioral disorder? And then also there is the social pragmatic communication disorder that is an option in addition to the ASD diagnosis, or maybe unspecified communication disorder you might also need to consider depending on the totality of the data. So when you talk about IDEA and DSM-5, we can't leave out the World Health Association International Classification of Diseases classification system, right? And if you look at ICD-10, effectively the criteria for autism spectrum disorder mirror those in the DSM-5. Now, I should tell you that another component that's included in DSM-5 relates to the criteria for autism from previous versions of the Diagnostic and Statistical Manual, so DSM-3 and DSM-4. And one of the things in the DSM-5, we're told an individual with a well-established DSM-4 diagnosis of either autistic disorder, Asperger's syndrome, childhood disintegrative disorder, Rett's disorder, or PDD, not otherwise specified, PDD NOS, that they should be given the diagnosis of autism spectrum disorder using the DSM-5. So again, certainly, especially high-functioning individuals, we might, in terms of ability, we may want to identify certainly the high level of cognitive abilities that would associate closer to the Asperger syndrome in previous versions of the DSM. So in terms of the assessment, we're thinking here, the evaluation, you're thinking about the importance of differential diagnosis, right? So the question that you ask is, are any social and communicative deficits that you observe, any stereotypic repetitive behaviors that you observe, are they uniquely associated with ASD, or can they be explained by other conditions? I mentioned those blindisms, for example. What if the child also has a visual impairment? Might those blindisms, the rocking behavior, the hand flapping, might those be associated with a visual impairment and not with the ASD? So it's really incumbent upon us to engage in this rule in, rule out process when we're conducting an ASD evaluation. And we think about some of the conditions that co-occur with ASD, and I mentioned intellectual disabilities previously when I was talking about the DSM-5, and the ASD and ID co-occur at relatively high rates, although a number of individuals with ASD do have average intelligence and sometimes above average intelligence. So again, some of these studies that I have listed here appear in a textbook, Read, published in 2018, that looks at language development. So in terms of ASD and intellectual ability, notice over here to the right in the purple, about 31% of individuals, and this information comes from Autism Speaks, 31% of individuals who are diagnosed with ASD also have an intellectual disability. Their IQ scores are lower than 70. But at the same time, notice that 44% have IQ scores above 85. So again, think about what these data tell you. In addition to its comorbidity with intellectual disabilities, ASD and motor behavior deficits often co-occur. About 80% of individuals diagnosed with ASD also exhibit deficits in overall motor planning, including oral motor planning related to speech. And that reminds me of little Jack that I talked about earlier, right? And then also sensory processing deficits. Almost all individuals with ASD have differences in dealing with sensory input. So my evaluation should include an assessment of sensory processing. And then in terms of hearing loss, according to Gallaudet, 1 in 53 children who are deaf are diagnosed with ASD. Again, thinking about those comorbid conditions, which effectively we need to rule out before we can get to a diagnosis of ASD. And then another one would be seizures. Approximately a third of individuals with ASD develop epilepsy during early childhood. And what about some co-occurring developmental disorders? ADHD. 21% of individuals with ASD also have ADHD. Language disorders, 63%. That one doesn't surprise us. Communication is one of the hallmark criteria for the ASD diagnosis. And then 6% have a concomitant learning disability. So when you think about an ASD evaluation, certainly it's important for us to focus on the evaluation of social communication, social interaction, the restricted repetitive patterns of behavior. But we also need to include developmental testing, a general developmental evaluation, standardized cognitive testing, an assessment of language, because our job is to differentiate ASD from other developmental difficulties. So there are a number of researchers, and one of our colleagues, Dr. Elaine Fletcher Jansen, talks a lot about when you have a referral for an autism evaluation, you want to make sure that you focus first on ruling out comorbid conditions. So I worked for a school district a number of years ago, and we had a specialized team of school psychologists. We call them the autism team. But when we got a referral to the autism team, the school psychologist assigned to the school would begin by conducting a comprehensive psychoeducational evaluation, and then that information was sent to the autism team, who would then focus on the ASD specific components of the evaluation. So when you think about a comprehensive evaluation, you're thinking about multi-source, multi-method, multi-discipline. You want to make sure that you involve parents, you review records, you interact with the pediatrician, get the medical history information, family history, social history. It didn't talk about causes of ASD here, just in the interest of time, but certainly we know that there is a genetic component when you think about ASD. So getting the family history information is really important. Information about communication development, language development. How old was the child when he or she started to babble, to coo, to vocalize, to repeat vowel sounds, to repeat consonants? What about motor development? How old was the child when she started to walk? What about educational history? So again, reviewing records, interviewing parents. And then you also want to interact directly with the child to collect information from the child, him or herself. And one of the things that some researchers talk about, and I have a study from Huerta and Lord that talk about, when we work on ASD evaluations, we have individuals or professionals from multiple disciplines. And that's often good for us, right? But when we think about the child who might be struggling with some of those social communication skills, do we actually tax the child even more by having him or her interact with multiple individuals? So for example, if you think about the areas on which we want to focus, we definitely need to assess behavior using some kind of broadband measure that will allow for differential diagnosis. Maybe I want to be able to tease out ADHD symptoms from ASD symptoms. So for example, the third edition of the Behavior Assessment System for Children that would provide me with an ADHD probability index, an autism probability index. I also need to assess cognitive functions, verbal and nonverbal. The data in a number of situations indicate that individuals with ASD tend to perform better on measures of nonverbal ability. And I'll talk about that in just a second when you think about factors you need to consider, right? Because verbal ability might be a relative weakness for the child. You also want to make sure that you focus on attention. You include some measures that'll assess attention. Executive functions, again, another key area when you think about ASD. And I mentioned theory of mind earlier. So like the NEPC2, that would include components that will provide information about attention, executive functions, and theory of mind. And then certainly communication in language. You're thinking certainly about receptive and expressive language, but also you're thinking maybe about metalinguistics that'll focus more on maybe the pragmatics of language. You're thinking about understanding of idioms and so on, understanding of figurative language. And then academic achievement. I need to be able to document that the symptoms adversely affect academic achievement. And then what about functioning in my social environment, in my day-to-day environment? Adaptive behavior is important for that purpose. And certainly motor skills, I need to rule out any kind of motor disability. And even if there is no motor disability, might the child require occupational therapy and or physical therapy as a service related to the ASD classification in the school setting? And then certainly sensory processing as well. One of the things that you could see from all of these areas that you want to assess is that you're thinking about professionals from multiple disciplines, right? The psychologist, you're thinking about the speech language pathologist for maybe adaptive behavior. I've worked in school systems where the social worker collected the information for adaptive behavior, sensory processing, maybe the occupational therapist, motor skills, maybe occupational therapist and physical therapist. So again, think about how this information actually is collected and who would be involved in the collection. And then once you conduct that general psychoeducational evaluation, you also want to assess the core symptoms of ASD. And you want to use specific tools that focus on autism, right? So for example, the ADOS is one. When I talked about the autism team earlier, they were all trained to use the ADOS, and certainly that is one that would be important as well as other tools like rating scales, like the Childhood Autism Rating Scale, the CARS-2 or the GARS-3, for example, would be options. So when you think about factors to consider when you have a referral for ASD, is what can we do to increase the rate of early identification? And I think the research is clear, and the American Academy of Pediatrics really talks about the importance of conducting developmental surveillance at every well-child visit to administer developmental screenings at certain ages, 9 months, 18 months, 30 months, and to recommend additional screening before the child begins preschool or kindergarten, or when the child comes at the age of 4 years. So really working with the developmental pediatrician. And then also thinking about a comprehensive developmental evaluation. So for example, when you think about individuals diagnosed with autism spectrum disorder, their performance on a developmental measure like the Bayley-4, for example, if you look here at the column, the ASD mean, cognitive, receptive communication, expressive communication, fine motor and gross motor, the mean score here would be 10. Notice the mean for the ASD group, 4, 3, 5. compared to the mean for matched control group that is close to the average, which is 10. And the difference between the mean for the two groups is significant when you look at the p-values here. And then also you look at the magnitude of the difference in that standard difference column. And of course, when you think about the lowest scores, shouldn't surprise us, receptive communication and expressive communication, 1.75 is the standard difference for receptive communication, 2.01 for expressive communication. Again, that does not surprise us. And then the other thing that you want to consider when you think about working with individuals with ASD is the fact that we know that they struggle to focus and sustain attention. We know that they struggle to understand verbal instructions. We know that they struggle to interact with different professionals. So if we're going to be effective, we need to understand how the symptoms of ASD may interfere with the administration of the tests that we need to present. So for example, for this little 5-year-old, if I am going to have trouble understanding his speech, what am I going to do to make sure that I maybe choose a measure that requires him to point? If I want to know if he knows the meaning of a word, maybe instead of asking him to tell me what the word means, I can ask him to show me, like using a test like the Peabody Picture Vocabulary Test, for example. Okay. So I think in summary, when conducting comprehensive evaluations for ASD, use instruments designed to assess multiple domains of functioning, include parents and caregivers, and consider developmental factors throughout the process. So I think that brings us to the end. I've included some references for you, but just because we're going to cut off here at the top of the hour, we want to thank you for attending. If your question did not get answered, please enter it into the box that'll pop up at the end. And again, let us know if you would like us to present other topics, and go to our website and you will see some of the other webinars that will be presented in the coming weeks, like sensory and motor skills, assessing language skills, adaptive behavior profiles for ASD.